Yeah, ready.
Okay, a 25-year-old, a 25-year-old man, a 25-year-old man comes to the emergency department because of 1 week history of right knee pain and swelling, of 2 day history of pain and swelling of the left elbow. He has not has any other symptoms. He has no history of serious illness, take no medication. His temperature is 100.4 degree Fahrenheit, pulse is 80 per minute, respiration 16 per minute, blood pressure 140 by 70. A pulse oximeter on room mirror shows oxygen saturation 100%. Physical examination discloses a swollen and erythematous left elbow. Passive and active range of motion of the elbow is limited. Radial pulses are 2 plus. Bilateral examination of the right knee discloses swelling and erythema. Active and passive range of motion of the knee is limited. Arthrosynthesis is done. Sample field analysis show leukocyte count 75,000 grams stain shows no organism. Negative for crystalline. In addition to culturing the synovial fluid of the elbow, which of the following is the most appropriate?
Ready?
Yes.
Sculpture of urethral swab. Neisseria, STI, gram-negative pneumococci, can cause pharyngitis, urethritis, epididymitis, vaginitis, cervicitis, PID. It can also cause disseminating infection if it persists untreated. When the patient presents with disseminating infection, there are often no preceding symptoms suggesting of STI infection. This patient presents with fever, malaise, polyarthralgia, oligoarthritis, tenosynovitis, vesiculopuscular dermatitis. However, patients may also present solely with purulent arthritis as of one or more extremities like knee, elbows, ankles. Further evaluation of the septic joint as evidence in this patient by swollen um, red joints includes arthrosynthesis with synovial fluid analysis. In the setting of gonococcal arthritis, the synovial fluid leukocyte count will be greater than 20,000 to 50,000, but no organism will be visible on gram stain because Neisseria gonorrhea is an intracellular. Blood cultures and cultures of the synovial fluid should be obtained. And therefore, in this patient whose arthralgia are likely caused by disseminated gonorrhea, cultures of urethral swab should also be collected to diagnose underlying gonococcal infection. It is not safe. Azithromycin, oral acetylene, may be warranted in the treatment of this patient. It's effective against chlamydia, which is a common co-infection with gonorrhea. However, prior treatment with antibiotics, prior to treatment, a urethral culture should be obtained to confirm gonococcal. And it's not a serum anti-step O test. Can be used to diagnose rheumatic fever, which presents with fever, arthritis, nodules, erythema, marginotopancreatitis, Sydenham chorea, following a strep infection. This patient is presenting only with oligoarthritis, making gonococcal infection more likely. Next.
A 37-year-old woman comes to the emergency department. 9 hour history of severe headache and vomiting that begins suddenly. She describes the headache as the worst of my life. It began while she was working on her computer. She has not had fever, trauma to the head, or sensitivity on light sound. She has no history of serious illness, takes no medication. Temperature is 37 degrees Celsius, pulse 92 per minute, respiration 16 per minute, blood pressure 124 by 78 millimeter of mercury, pulse oximetry on room air of the oxygen shows an oxygen saturation 99%. Examination shows no neck pain, rigidity. Neurologic examination shows no focal finding. A CT scan of the head shows no abnormal. CT scan of the head shows no abnormality. Which of the following is the most appropriate next step in the evaluation?
Hmm. Ready?
1 minute, please.
Do you think we go straight to lumbar puncture or do
Are
we
you
do
think
MRI?
are you thinking about a IIH? What is your
What? No,
diagnosis?
no, I was just no, I thought it was just like that subarachnoid hemorrhage.
Somewhere.
I mean,
Yes, if CT scan is inconclusive, then we can do a lumbar puncture to see the RBC.
but but you know, worst headache of my life is usually like it's subarachnoid. What was it? Is it? I know it's one of the
Yes,
hemorrhage,
subarachnoid hemorrhage. Yes, worst of my life.
but then it says no neck pain, no rigidity, no
No, no
nothing.
rec pain. This goes for meningitis.
Oh, okay, okay. So it's subarachnoid, but no meningitis.
Yes.
Okay, okay, okay.
Ready?
Yeah. Lumbar puncture. Non-contrast CT scan of the head is highly sensitive, but not perfectly sensitive method for detection of subarachnoid hemorrhage. The sensitivity of CT scan for subarachnoid decreases over time from the onset of bleeding or with smaller volume of hemorrhage. Patients with presenting history concerning of subarachnoid who have negative CT should undergo emergency lumbar puncture. Lumbar puncture is useful for identifying findings of subarachnoid, including xanthochromia, increased opening pressure, and increased CSF of red blood cells that does not clear across several tubes of collected fluid. CT scan is most sensitive to detect subarachnoid within the first 6 hours from the onset of symptoms and may reveal hyperdense blood products in the subarachnoid space. It's not MRI has a high sensitivity to detection of subarachnoid hemorrhage, but it is time-consuming study will result in the real treatment done by puncture allows for more immediate detection. Okay, next.
Which of the following is the most appropriate to administer? A 62-year-old woman is brought to the emergency department by her husband because of today's history of generalized weakness. The husband reports that the patient has had a poor appetite during this time and has not gotten out of the bed today. He noticed that she was not able to provide coherent answer to questions. The patient's medical history include hypertension, type 2 diabetes, coronary artery disease with stenting, and bipolar disorder. He notes that he has not taken any other medical for the past 5 days. He prescribed medication lisinopril, hydrochlorothiazide, metformin, clavuroate. He has no allergy, alcohol beverage. Patient is drowsy but responds to her name. Patient is on arrival. Patient is drowsy, responds to her name. She is oriented of only person and is unable to engage with coherent conversation. Temperature is 99 pulse 128, respiration 20, blood pressure is high 178 by 94, pulse oximeter on room air show 99%. She moves all her extremities spontaneously but does not comply with physical neurologic function. Fingers shake, blood sugar concentration is too high to calculate the fingers shake, glucose is high to calculate the determined to be high with for spontaneously but does not comply the full range of mm, sodium is low 128, potassium bit low, uh, bicarbonate is low, glucose is very high. In addition to 0.9% sodium chloride, which of the following is to administer? Ready? It is DK, isn't it?
It is DK, like, or what is it? No,
HHS.
that's HH, whatever.
I think okay, it's HHS.
Okay,
Hyperglycemic hyperosmolar state.
ready.
Yes.
So, potassium. Oh, I know what one is the other. Okay, the potassium should be given in conjunction with saline in this patient with HHS and hypokalemia. HHS is a consequence of profound hyperglycemia and manifests with increased glucose concentration above 600. Altered mental status, hypovolemia in the absence of ketosis. It is more common than DKA in patients with type 2 diabetes. Glucose is an osmotically active substance and can, at high concentration, leads to dramatic increase in the osmolarity of the serum with consequent mental status changing. Of other common lab findings include pseudohyponatremia, increased serum osmolarity, and hypokalemia without metabolic acidosis. The treatment is IV hydration and insulin. IV potassium supplementation should always be given before insulin if the serum potassium concentration is below 3.5, as insulin causes potassium to shift into the cells, which can lead to hypokalemia with subsequent cardiac arrhythmias. The potassium concentration should be monitored during IV insulin administration and should be repleted when it falls below 3.5. It is not hypertonic. Saline is not appropriate for this patient and could potentially lead to worsening her condition. Hypertonic saline is typically reserved for patients with increased intracranial pressure and those with severe symptomatic hyponatremia. Insulin is necessary part of the algorithm for HHS, but when given before potassium, it can result in hypokalemia. Yeah, those potassium should be given first. Next.
Yes. A 20-year-old man is brought to the emergency department 45 minutes after he developed nausea and unsteady gait, muscle cramps, headache while running in a marathon. On arrival, he is confused and disoriented. His temperature is 104, pulse is 155, blood pressure 100 by 60. Examination shows warm skin and diaphoresis. Neurological examination shows. Okay, okay, ready?
Okay. So it is inadequate dissipation of body heat. Athletes are at increased risk for heat exhaustion or heat stroke as a result of strenuous exercise, hot temperatures, and increased humidity. Other risk factors include lack of acclimatization, obesity, dehydration, poor physical fitness. During exertion, the body is able to dissipate heat by increasing blood flow to the skin and producing sweat to facilitate evaporative cooling. However, when ambient temperature is increased and humidity is high, these mechanisms are less effective at dissipating heat, potentially resulting in heat exhaustion or heat stroke. Heat exhaustion is characterized by exercise intolerance, high uh, hyperthermia, and the absence of neurologic disturbance. Heat stroke is characterized by hyperthermia, alterment status, neurologic deficit, and variable physical signs and symptoms depending on severity. In this case, this patient was running a marathon and was susceptible to overheating from the environment. His exam shows tachycardia, hypotension, warm, flush skin, lab workup may disclose hypernatremia, hyperchloremia, hyperkalemia, so all hyper, along with increased serum creatinine, urea, and CK concentrations. Management of heat-related illness involve removing the individual from heat, removing excess clothing, and initiating cooling measures such as immersion in cool water or evaporative hyperkalemia. Okay. Why is everything hyper? Hyperchloremia, hypernatremia. You know,
Why everything is hyper?
in whatever heat exhaustion or whatever.
Because in heat exertion, hyperkalemia happens. Maybe muscle is breaking down, so release of the
Mhm.
potassium. And and hyperchloremia. I don't know. I can describe hyperkalemia due to breakdown of the muscle during heat exhaustion or heat stroke.
We ask a minute. Why
Yes.
is the hypernatremia and hyperchloremia during heat exhaustion? Heat exhaustion and penalty appeal due to body fail response to dehydration. It is also loss of water. Okay, okay, got it.
So lots of fluid is losing. So there is the remaining salt causing hypernatremia, isn't it?
Mm-hmm.
So it is hypovolemic hypernatremia.
Okay, okay. Next.
A previously healthy 3-year-old boy is brought to the emergency department 1 hour after he fell off a boat during a lake party. He was submerged on approximately 1 minute and initially had difficulty breathing or a severe cough when he pulled from the water. He currently is asymptomatic. Pulse is 110 per minute. Respiration is 30 per minute. Blood pressure is 90/50. Pulse oximetry on the room air oxygen show oxygen saturation is 92%. Physical examination shows no abnormality. Which of the following is the most appropriate? A mechanism of next step in the management. Okay, okay, ready?
Yeah. This observation for serial exam. Near drowning in children can result in a variety of clinical presentation depending on the severity of the drowning incident. Patient can present with aspiration, hypoxemia, respiratory distress, laryngospasm. Hypoxemia can lead to ischemic neuronal damage resulting in cerebral edema. In the case of drowning, aspirated fluid causes local inflammation of the lung, along with the dilation of surfactant, leading to impaired compliance airspace infiltration. This can result in persistent and severe hypoxia despite management with positive and expiratory pressure and increased fraction of oxygen. Asymptomatic patients should be observed in the ED and admitted to the hospital if any clinical deterioration occurs. Symptomatic patients or patients who have continued hypoxia should be admitted to the hospital and be monitored until symptoms of hypoxia resolve. Point of time evaluation is generally insufficient in these cases, as neodramic can result in progressively worsening inflammation and hypoxia over hours to days, such that an initially normal evaluation may be falsely reassuring. It's not key. Rapid sequence intubation will be appropriate in patients with severe respiratory distress, hypoxic and or hypercarbic respiratory failure, and neurologic deterioration. This patient is not in respiratory distress and intubation is not indicated. Next.
Yes. A 23-year-old woman with asthma comes to the emergency department because of 24-hour history of abdominal pain, mild nausea. She says the pain was initially generalized but now is concentrated in the right lower abdomen. He has not had vomiting upper he has not has vomiting, urinary symptom, vaginal discharge or bleeding. Means occur at regular interval lasts for 4 days. Her menstrual period was 3 weeks ago. She is sexually active with one male partner. They use condom consistently. A home pregnancy test is negative on arrival. She appears uncomfortable. His temperature is 38.7, pulse 113 per minute, respiration 22 per minute, blood pressure 119 by 54. Pulse oximetry on room here. Oxygen saturation is 98% of dental examination. Pain management.
Mm. Ready?
Okay.
This IV morphine. This patient is presenting with fever, abdominal pain, she has fever, yeah, and tenderness on the right lower quadrant, raising suspicion appendicitis. Appendicitis present with right lower quadrant abdominal pain that is often periumbilical at onset, along with nausea, anorexia, fever, leukocytosis, tenderness to palpitation in the right lower quadrant. This patient has also has sign of ruptured appendicitis, with peritoneal signs such as rebound and guarding. Patients with appendicitis and other intra-abdominal infections typically have acute severe pain that should be treated immediately. Morphine is an opioid analgesic used to manage moderate to severe pain. It acts on mu opioids receptors to provide pain relief and is available oral IV IM suppository. It's a potent analgesic that will be effective in treating this pain. Ketorolac can be used to treat moderate pain, but this patient likely has severe pain from complicated appendicitis, peritoneal signs. It will likely be inadequate in treating this patient pain. Additionally, this patient will require surgery, and ketorolac and NSAID presents an adverse effect of bleeding because of its effect on prostaglandin pathways. Oral acetaminophen and oral oxycodone should not be given to this patient awaiting for surgery. Oral medication should be avoided in patients who may require emergency surgery, such as this patient, because of the risk of aspiration under anesthesia. Next,
Yes. So why morphine?
because she has severe pain.
Okay. A 45-year-old woman is comes to the emergency department because of 2 day history of pain and swelling and of the redness in the right knee. She is unable to bear weight of the knee. She has had she has had no trauma. The patient has a history of hypertension with hydrochlorothiazide, chlordiazide oxide. The right sneeze, swelling, erythematous. Passive range of movement of the knee is full, but active range elicits bend. Passive range full, elicits bend. The RC dorsal repeat is a 2 plus bilaterally. Measurement of one from the diagnosis. Mm, 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 mm.
Ready?
Yes.
The synovial fluid crystal analysis is what we need to confirm the diagnosis. This patient right knee pain, swelling, redness, most likely gout, and is experiencing acute flare. Gout, inflammatory joint disease that's caused by the precipitation of uric acid crystals in the joint space, which are highly inflammatory and lead to swelling, redness, pain. The most common affected joints are the first metatarsophalangeal joints, but knees, elbows, wrists, and other joints can be involved. The diagnosis is made definite by analysis of the joint x-ray, which is demonstrate needle-shaped crystals that are negatively birefringent. Aside from synovial fluid, crystal analysis is also important to perform cell count and culture on the joint as pleural infection, aseptic arthritis, and acute gout can exist together in the same patient and is in the same joint. Treatment for acute gout attacks include the use of NSAID, colchicine, and steroids. Long-term urate lowering therapies indicated in patients with kidney disease, tophaceous gout, and those with frequent gout attacks. It's not C. Serum uric acid concentration may be deceiving low during acute gout flare and is not used to make a diagnosis of gout. While many patients with gout have increased uric acid concentration, there are also many patients with increased uric acid concentration that do not have gout. Ah, interesting. Next.
Next. A previously healthy 36-year-old man comes to the emergency department because of 1 hour history of nausea and sharp intermittent pain in the right mid-back. On that radius to the right flank, he has 2 episodes of vomiting during these days. She has no medication. Temperature is 37 degrees Celsius, pulse 90 per minute, respiration 20 per minute, blood pressure 140 by 60, pulse oximeter on the room here show oxygen saturation 100%, physical examination show tenderness to percussion in the right costovertebral angle. No abdominal tenderness is seen. CT scan of the abdomen shows which of the following is the most appropriate next.
I don't see shit on the CT scan. Think about
Picture is not giving anything, is giving clue.
what does he have? I mean, he doesn't have fever. Has pain in the back that radiates to the costovertebral angle pain. So like like a kidney stone.
Sorry.
What does he have? Like a kidney stone?
If kidney stone like nephrolithiasis or
Yeah, sorry, it's nephrolithiasis.
nephrolithiasis called high grade fever, isn't it?
Does you? Because for me it's either C or E, but ceftriaxone he doesn't have no fever. It doesn't make sense.
Yes. And 36 CRE, tamsulosin, very unlikely.
They like it stumps. I don't know. Let's pick one. The other ones don't make sense to me. I don't know why. Ready?
Yes.
Yeah, it's tamsulosin. The other ones don't make sense. Renal calculus or nephrolithiasis typically causes symptoms of unilateral acute flank or back pain, nausea, vomiting, and hematuria. There are three main sites of anatomic narrowing along the ureter that may obstruct the passage of the stone. At the ureteropelvic junction, at the renal pelvis, and at and the ureter. The uterovesicular wait at the ureteropelvic junction of the renal pelvis and the ureter. Okay, so up there. The uterovesical junction as the ureter enters the posterior bladder. Okay, and at the pelvic inlet when the ureter crosses the common iliac vessel bifurcation. Okay, got it. This patient CT scan demonstrates a ureteral calculus at the site of the ureterovesical junction. Let's see, where is it? Oh, sorry, it's right here. You see it? It's
Yes.
like a white thing. It's so little.
Only one stone.
Yeah, it's like this, but it's so little you can't even see it on the. Anyway,
And
um,
this is causing so much trouble. Only this
I
small.
maybe the CT scan just shows it little. Maybe it's not. I don't know. The initial management of kidney stone includes oral fluid hydration, analgesia, pharmacotherapy uh, to facilitate the passage of the stone. Alpha blockers such as tamsulosin cause ureteral smooth muscle relaxation, which encourage passage of the calculus. It's not C. Ceftriaxone is useful for management of pyelonephritis. Pyelonephritis also presents with acute onset of nausea, vomiting, and flank pain, but is typically accompanied by fever. That's the key. Okay, next.
Yes. 45-year-old man is brought to the emergency department 4 hours after sudden onset of severe shortness of breath. She has coronary artery disease, chronic obstructive pulmonary disease, recurrent pneumonia, congestive heart failure. His medications are albuterol, prednisolone aspiration. On arrival, he appears pale, levered. His temperature is 37, pulse 124 minute, blood pressure 235 by 103, pulse oximeter 85%, chest X-ray show disclosed no abnormality, diffuse crackles are heard on the lung field. Vital signs are breath sounds and air movement is decreased. There is moderate pitting edema in the right lower quadrant. An X-ray is shown. Which of the following is the most likely diagnosis? IMP is high. 1 second, please. Okay, ready.
So it's cardiogenic pulmonary edema. Cardiogenic pulmonary edema results from increased feeling pressure or impaired forward flow in the heart. This increases hydrostatic pressure in the pulmonary venous circulation, resulting in transudation of fluid from the pulmonary capillaries into the pulmonary interstitial and alveolar space, impairing gas exchange. Cardiogenic pulmonary edema can be brought on suddenly by increase in blood pressure known as flash pulmonary edema, which is likely the cause in this patient. Patients with cardiogenic pulmonary edema typically experience progressive dyspnea on exertion and then at rest, paroxysmal nocturnal dyspnea, and apnea. Physical exam findings include hypoxia, crackles, and decreased breath sounds. Initially, crackles will present only in the dependent region of the lungs, but with increasing severity, edema will spread involve the lung fields diffusely. This patient lower extremity edema further suggests a status of volume overload. The chest area also demonstrates diffuse interstitial infiltrates, suggesting of pulmonary edema. It's not COPD exacerbation characterized by shortness of breath and shallow respirations with wheezing on physical exam. Accumulation of CO2 as a result, inability to fully expire will also cause respiratory acidosis, which may present with altered mental status. The patient physical exam findings are more consistent with cardiogenic. Okay. Next.
Yes. A 22-year-old woman is brought to the emergency department because of 6 hour history of severe right lower abdominal pain and near loss consciousness. She also has 2 week history of vaginal bleeding. Her last menstrual period was 45 days ago. Men's previously occurred at regular 28-day intervals. She has no history of serious illness, take no medication. She is sexually active with one male partner. They use condoms inconsistently. Her temperature is 37 pulse 104 per minute, blood pressure 85 by 55. Abdominal examination shows oxygen saturation. Abdominal examination show right lower quadrant bleeding on deep palpation. Physical examination shows small round dark blood in the vaginal wall. The cervical os is closed and there is no active bleeding. The uterus is soft, non-tender. Lab studies show hemoglobin concentration is 10. Which of the following is most likely diagnosed? Because I thought it was.
Ready?
Is it ectopic?
Probably.
Okay.
So is ultrasound of the pelvis. Pregnancy is suspected when there is miss or delay period. Ectopic is non-viable abnormal pregnancy which the fertilized hormone implants in the fallopian tube, ovary, peritoneal cavity. An ectopic pregnancy often presents vaginal bleeding, abdominal, pelvic pain early in the pregnancy caused by the restricted area for fetal to grow. Physical exam may demonstrate that nasal tenderness on the side of implantation as well as tenderness to palpation of the lower abdomen. Topic pregnancy can be complicated by rupture, bleeding, hemoperitoneum, which can present with signs of hemodynamic instability. Tachycardia, hypotension. Ultrasound can be used to evaluate for intrauterine pregnancy and may potentially visualize the location of ectopic pregnancy, making it most appropriate next step. Ectopic pregnancy can be managed medically using methotrexate for small early pregnancy, but may require salpingectomy and evacuation with laparoscopy for larger pregnancy. Cases of medical treatment failure in cases of complication such as rupture. It's not CT scan of the abdomen and pelvis may disclose a diagnosis of ectopic pregnancy. However, it exposes the patient and fetus, if it's a viable intrauterine pregnancy, to unnecessary radiation. Ultrasound will be first to evaluate this patient. Next.
Okay. Can I stop here?
Sure.
Yeah.
Yes. Okay. I'll
Okay.
see you tomorrow.
Okay. And so tomorrow our journey of like CMS form will over.
We'll be done.
Okay. Then we will start the you will teach me my your